Hello, dear students. The topic of our lecture is anemias. Let's start. Definition of anemia. Anemia is best defined in relation to H&H, hemoglobin, and hematocrit levels below the normal reference range because a patient's symptoms and physiologic consequences are the result of decreased oxygen carrying capacity of the blood. According to World Health Organization criteria, anemia is diagnosed in males when hemoglobin is less than 130 gram per liter and hematocrit is less than 39%. In non-pregnant females, when hemoglobin is less than 120 gram per liter, and hematocrit is less than 36%. Pathological anemia classification: blood loss, acute and chronic, decreased production, deficiency anemias, iron deficiency, vitamin B12 and folate deficiency, bone marrow disease, increased destruction, inherited, acquired. Morphologic anemia classification. Morphologic classification subdivides anemia into macrocytic anemia, normocytic anemia, and microcytic hyperchronic anemia. The main advantages of this classification, other than the classification is simple, is based on readily available red cell indices, for example, mean corpuscular volume and mean corpuscular hemoglobin concentration. The functional classification of anemia has three major categories. There are marrow production defects, red cell maturation defects, and decreased red cell survival. In the first branch point of the classification of anemia, reticulocyte production index more than 2.5 indicates that hemolysis is most likely. Reticulocyte production index less than 2 indicates either a hypoproliferative anemia or maturation disorder. A hypoproliferative anemia is typically seen with a low reticulocyte production index together with little or no change in red cell morphology. Maturation disorders typically have a slight to moderately elevated reticulocyte production index that in accompanied by either macrocytic or microcytic red cell indices. Increased red blood cell destruction secondary to hemolysis result in an increase in the reticulocyte production index to at least 3 times normal, provided sufficient iron is available. Anemia classification according to the degree of severity. First, mild. Hemoglobin is 120 to 90 gram per liter. Moderate. Hemoglobin is 90 to 70 gram per liter. And severe. Hemoglobin less than 70 gram per liter. Iron deficiency anemia. Iron deficiency is defined as a decreased total iron body content. Iron deficiency anemia occurs when iron deficiency is severe enough to diminish erythropoiesis and cause the development of anemia. Iron deficiency is the most prevalent single deficiency state on a worldwide basis. Causes of iron deficiency and iron deficiency anemia. First, growing infants and children, menstruating women, pregnancy, lactation, parturition, low socioeconomic status, vegetarian diet, lack or balanced diet or poor intake, alcoholism, elderly, high-risk ethnic groups, menorrhagia, GI bleeding, regular blood donors, post-operative patients with significant blood loss, hematuria, intestinal parasites, hemolytic hemolytic anemias, extreme physical exercise, and dietary factors, upper GI pathology, chronic gastritis, gastric lymphoma, celiac disease, Crohn's disease, medications that decrease gastric acidity or bind iron, gastrectomy or intestinal bypass, duodenal pathology, chronic renal failure. Anemic syndrome. Three pathogenetic mechanisms contribute to the anemic syndrome. First, hemic hypoxia refers to the decrease in amount of hemoglobin in the blood. Tissue hypoxia, which is the reduction of oxygen supply to a tissue below physiological levels, despite adequate perfusion of the tissue by blood, and decreased viscosity of blood. Symptoms of anemic syndrome are dyspnea, heart pain, palpitations, heart failure, feeling of lack of air, fatigue, headaches, daytime sleepiness, dizziness, fainting, hypersensitivity to cold, chillness, weakness, fatigue during exercise. Due to vasoconstriction of the arterioles of the skin and mucous membranes, a pallor of skin, palmar creases, and conjunctiva appears. Plummer-Vinson syndrome. The syndrome is associated with dysphagia, iron deficiency anemia, is not associated with anemia. Angular cheilitis. Angular cheilitis is an inflammatory lesion at the labial commissure or corner of the mass, and often occurs bilaterally. Cheilitis is a medical condition involving inflammation of the lip. Glossitis is inflammation of the tongue. KOILONYCHIA, also known as spoon nails, is a nail disease that can be a sign of hypochromic anemia, especially iron deficiency anemia. It refers to abnormally thin nails which have lost their convexity, becoming flat or even concave in shape. Cytopenic skin change, poorly healing wounds and injuries. Dry, exfoliating, itchy skin. Stage of iron deficiency. Stage 1, pre-latent iron deficiency. Stage 2, latent iron deficiency. Stage 3, iron deficiency anemia. Management of iron deficiency. Three main strategies can be applied order to improve iron status in individuals and populations. Dietary modification, food fortification, iron supplementation. Dietary iron sources include meat, fish, poultry, lentils, dried beans, grain products, vegetables, dried fruit, and molasses. Treatment guidelines from the American College of Physicians for adult patients with anemia and iron deficiency include the following. Restrictive red blood cell transfusion strategy is recommended for hospitalized patient with coronary heart disease with the trigger hemoglobin threshold lowered to 7 and 8 gram deciliter. Erythropoiesis stimulating agents are not recommended for patients with mild to moderate anemia and either congestive heart failure or coronary heart disease. Vitamin B12 deficiency anemia. The term pernicious anemia is an anachronism. It dates from the era when treatment had not yet been discovered and the disease was fatal, but it remains in use for megaloblastic anemia resulting from vitamin B12 deficiency due to lack of intrinsic factor. Megaloblastosis describes a heterogeneous group of disorders that share common morphologic characteristics. Large cells with an arrest in nuclear maturation. Nuclear maturation is immature relative to cytoplasmic maturity. Hence, these cells, which can be seen in bone marrow aspirates and in peripheral smears, have been called megaloblasts. These abnormalities are due to impaired DNA synthesis and to a lesser extent RNA and protein synthesis. Megaloblastosis can be associated with severe anemia and pancytopenia, gastrointestinal dysfunction and glossitis, personality changes, psychosis, and neurological disorders. Vitamin B12 and folic acid deficiency and certain medications are the most common causes of megaloblastic anemia, macrocytic anemia. The adult form of pernicious anemia is most prevalent among individuals of either Celtic or Scandinavian origin. Pernicious anemia is reported less commonly in people of other racial backgrounds. Also, the disease was once believed to be rare in Native American people and uncommon in Black people. Adult pernicious anemia usually occurs in people aged 40, 70 years. A female predominance has been reported in England, Scandinavia, and among persons of African descent. Cobalamin deficiency may result from the following: inadequate dietary intake, atrophy or loss of gastric mucosa, functionally abnormal intrinsic factor, inadequate proteolysis of dietary cobalamin, insufficient pancreatic protease, bacterial overgrowth in intestine, Diphyllobothrium latum, disorders of ileal mucosa, disorders of plasma transport of cobalamin, dysfunction uptake and use of cobalamin by cells. Physical examination. Evidence of anemia. Patients may be asymptomatic of the anemia, had developed gradually and was compensated. In severe anemia, patients may have dyspnea, tachycardia, and cardiopulmonary distress. Patients may have a lemon yellow hue due to the combination of anemia and an increased indirect bilirubin level. The source of the bilirubin in intramedullary hemolysis. Glossitis characterized by a smooth tongue due to loss of papilla occurs in persons with cobalamin deficiency. Dermatologic signs include hyperpigmentation of the skin and abnormal pigmentation of hair due to increased melanin synthesis. Infantile vitamin B12 deficiency is common in underdeveloped countries and is associated with hyperpigmentation of the dorsa of hands and feet, as well as generalized hyperpigmentation. A wide range of mental changes from irritability to psychosis, as well as peripheral neuropathy, can occur in both folate and cobalamin deficiencies. Subacute combined neurologic degeneration occurs in cobalamin deficiency. Patients present with abnormal gait, loss of balance, speech impairment, and loss of proprioceptive and vibratory senses. Blindness due to optic atrophy may occur. Abdominal scars may suggest a blind loop syndrome due to gastric surgery or a lack of ileal absorption of cobalamin in a patient who had an ileal resection. Patients should have diet management. Patients should have diets rich with folic acid. Examples of such foods include asparagus, broccoli, spinach, lettuce, lemons, bananas, melons, liver, and mushrooms. To prevent loss of folate, food should not be cooked excessively and should not be diluted in large amounts of water. To prevent cobalamin deficiency, vegetarians should include dairy products and eggs in their meals. Patient should know that whole milk contains little folate. Cobalamin therapy. Cobalamin should be given intramuscularly daily for 2 weeks, then weekly until the hematocrit value is normal, and then monthly for life. A dose of 1,000 milligram is large, but it may be required in some patients. Oral cobalamin also can be administered. Oral cobalamin is less expensive and is better tolerated by patients. Patients who have undergone either a total or partial gastrectomy should be started on replacement therapy after the surgery to prevent the development of megaloblastosis. Oral dosages should be monitored for the desired response, since absorption can be variable and may be insufficient in some patients. Folate therapy. Folate should be administered orally. If this is difficult, comparable doses can be administered parenterally. In addition, the patient should consume a folate-enriched diet. The dosage range for folate is 1 to 5 milligram daily. 1 milligram deciliter is the usual dosage for adults with megaloblastic anemia, while a higher dosage is indicated in hemolysis, malabsorption, alcoholism, and exfoliative dermatitis. However, there is no harm to giving the higher dosage of folate. Aplastic anemia. Aplastic anemia is a syndrome of bone marrow failure characterized by peripheral pancytopenia and marrow hypoplasia. Also, the anemia is often normocytic. Mild macrocytosis can also be observed in association with stress, erythropoiesis, and elevated fetal hemoglobin levels. Etiology included autoimmune factors, chemicals, drugs, hereditary, idiopathic factors, infections, and radiation. The clinical presentation of patients with aplastic anemia includes symptoms related to the decrease in bone marrow production of hematopoietic cells. The onset is insidious, and the initial symptom is frequently related to anemia or bleeding. Also, fever or infections may be noted as presentation. Specific manifestations include the following. Anemia may manifest as pallor, headache, palpitations, dyspnea, fatigue, or foot swelling. Thrombocytopenia may result in mucosal and gingival bleeding or petechial rashes. Neutropenia may manifest as overt infections, recurrent infections, and mass and pharyngeal ulceration. Physical examination. Physical examination may show signs of anemia. and of thrombocytopenia. Overt signs is infection are usually not apparent at diagnosis. A subset of patients with aplastic anemia present with jaundice and evidence of hepatitis. Findings of adenopathy or organomegaly should suggest an alternative diagnosis. In any case of suspected aplastic anemia, look for physical stigmata of inherited marrow failure syndrome, such as the following: abnormal skin pigmentation, short stature, renal, cardiac, and gastrointestinal abnormalities, microcephaly, microphthalmos, hypogonadism. Aplastic anemia treatment and management included blood transfusion, treatment of infections, hematopoietic cell transplantation, umbilical cord blood transplantation, immunosuppressive therapy, thrombopoietin receptor agonist therapy, diet and activity. Thank you guys for your attention. Goodbye.